All right. Okay, so this is, so let's go on to our next chapter. All right, next chapter. Okay. Next, let's have a look at all right. So next, let's have a look at the our next chapter, which I'm doing up is renal physiology with you. And the reason why I'm taking up renal physiology is this was a request from quite a few of you. And I think in medicine, you're starting with kidney. So a lot of people wanted you to be covered renal physiology first, right? So let me discuss renal physiology with you. Okay. All right. Vasant, hemisection, Brown-Séquard syndrome, all has been covered. Decorticate, all has been covered in medicine. You've already had a neuromedicine class, isn't it? You've had neurology in medicine, so all those are medical medicine questions. Decerebrate, decorticate rigidity is not physiological, Anna? Okay. Nikita. REM sleep is characterized by autonomic instability. Yes? So therefore, penile erections. Marvel, melatonin is secreted from the pineal gland. It rises during sleep. Yes, that's all. From the pineal gland. That is under the control of suprachiasmatic nucleus of hypothalamus. All right. Okay, so let's start with renal physiology. Now, as far as renal physiology is concerned, now renal physiology is the renal physiology. This is now, what are the three major processes? Decorticate, decerebrate, Dr. Augusta is covered in physiology. That is medicine now. I take it up in questions, but all right, okay. All right, so let's start with renal physiology. Let's see what are the major processes which go on in the kidney? What is excretion? Excretion is going to be filtration minus reabsorption. Filtration minus reabsorption. Filtration minus reabsorption plus the secretion. Filtration minus reabsorption plus the secretion. Okay? Dekho beta, one thing before I'm reading your questions, please understand what we do in class are must-know topics. What are must-know topics? These are topics which you should know very well when you're preparing for your NEET exam. Yes? Now, there are always must-know and there are desirable-to-know topics. Yes? Which are not essential, but you have one or two rare questions in central institutes, which I cover either in your GTs, hopefully you're all doing your grand tests, or we've covered in DQB. So once you mix up your class notes plus GTs plus DQB, you get a thorough everything, all small topics, important as well as not so important topics are going to be covered in physiology. Right? My aim in class is going to be to cover the must-know topics which are essential for your PG entrance exam. Is that okay? So there will be, see, like for instance, Santosh Kanpat, limbic system. Now we've already done bits and parts of limbic system, but limbic system as per se is covered in psychiatry. Have you understood? So there's an overlap here. And wherever there is an overlap, I will not do those points because time is a premium for us, isn't it? So we need to do those things which are not going to be, which are essential as far as your exam preparation is concerned. But you must understand class notes have to be combined with your grand tests, with your DQB, grand tests, and if possible, subject-wise test. We've covered all topics. Everything is covered in these four things put together. Okay. Debashish Nanda, class notes, DQB, grand test, and subject-wise test. These are your four essential things. Okay? All right. Now, next, let's see renal physiology. Like I said, what are the three major processes which go on in the kidney? This is going to be filtration, reabsorption, and secretion. These are the three important processes which go on in the kidney. So the excretion will be filtration, the amount of a substance filtered minus the amount which is reabsorbed plus the amount which is secreted. So let's take on the first is, what is the glomerular filtration membrane? Glomerular filtration membrane. Right? Glomerular filtration membrane. And what is the glomerular filtration membrane? Glomerular filtration membrane has got three layers. And what are these three layers? Three layers are going to be, number one is the glomerular capillary endothelium. Glomerular capillary endothelium. What is this glomerular capillary endothelium? This is a fenestrated endothelium. This is a fenestrated endothelium. Glomerular capillary endothelium is a fenestrated endothelium. There are large pores which are present. Large pores which are present. Right? Fenestrated endothelium, which is large pores which are present, and the size of these pores is 70 to 80 nanometers. 70 to 80 nanometers. Glomerular capillary endothelium, fenestrated, and large pores which are present. These are 70 to 80 nanometers. The second one is the basement membrane. This is what the glomerular filtration membrane. There are three layers. The second one is the the basement membrane, glomerular capillary endothelium and the basement membrane. The basement membrane has got no pores. Basement membrane has got no pores, but its permeability is equivalent. Permeability is equivalent to a pore size. Permeability is equivalent to a pore size of 8 nanometers. Yes, please remember the basement membrane has got no pores, but the permeability is equivalent to a pore size of 8 nanometers. Basement membrane also has the presence of sialoproteins or proteoglycans. Sialoprotein or proteoglycans which are present, and these will give a negative charge to the basement membrane. These proteins are present, and that also contributes to the negative charge in the basement membrane. Then the third layer is the when you look at the visceral layer of the Bowman's capsule. Visceral layer of the Bowman's capsule. This is modified. Visceral layer of the Bowman's capsule. This is modified. Visceral layers of the Bowman's capsules modified to form podocytes. Podocytes. What are podocytes? These have got foot-like processes. Podocytes have got foot-like processes. And between these foot-like processes, you have what are known as the filtration slits. And what is the size of the filtration slits? 35 nanometers, right? Now, or 30 to 40 nanometers, right? So let's see this once again. What are the three layers of the glomerular filtration membrane? Glomerular capillary endothelium, which is a fenestrated endothelium. There are large pores which are present. Basement membrane has got no pores, but the permeability is equivalent to a pore size of 8 nanometers. Basement membrane also has the presence of sialoproteins or proteoglycans, which give a negative charge. Visceral layer of the Bowman's capsule. Now, what is the visceral layer of the Bowman's capsule? If you look at the Bowman's capsule, This is the visceral layer. This is modified to form podocytes. Podocytes have these foot-like processes, and between the foot-like processes, you've got filtration slits. This is what this is the afferent arteriole, glomerular capillaries, efferent arteriole, right? So the endothelium, the basement membrane, and the visceral layer of the Bowman's capsule, they form 3 layers of a filtration membrane, right? These are your 3 layers. And what is going to be the limiting factor for filtration? Limiting factor for filtration is going to be the basement membrane, right? This is the limiting factor for filtration. Limiting factor for filtration. Why is it going to be limiting factor for filtration? Limiting factor for filtration, like I said, is the basement membrane, right? Why basement membrane is the limiting factor for filtration? Because, like I said, limiting factor for filtration, because, like I said, its permeability is equivalent to a pore size of 8 nanometers. Yes, 8 nanometers. This is the parietal layer. This is the parietal layer of the Bowman's capsule. Okay? All right. So this is as far as your the 3 layers. What is the limiting factor for filtration? Basement membrane. Now, important point to remember is neutral particles. Neutral particles more than 8 nanometers are not filtered at all, right? Neutral particles more than 8 nanometers are not filtered at all. Why are they not filtered? More than 8 nanometers are not going to be filtered at all? Because of the basement membrane, which is the limiting factor. So neutral particles more than 8 nanometers will not be filtered at all, right? Then you have the next important point is, now here is a question which has been asked. Which of the following has the least filtrability? Which of the following has the least filtrability? Is it going to be a substance which is 7 nanometers negative, 7 nanometers positive, 4 nanometers negative, 4 nanometers positive? Which is the one which is going to have the least filtrability, right? Which of the following has the least filtrability? 7 nanometers negative, 7 nanometers positive, 4 nanometers negative, 4 nanometers positive. Now, out of this, the one which is going to have the least filtrability is in fact 7 nanometers negative. 7 nanometers negative, right? So this is the one, and this is the effective diameter of albumin. This is the effective diameter of albumin. Have you understood? And normally, albumin is not filtered, isn't it? Albumin is not filtered. The effective albumin is not being filtered, isn't it? This is because even though it is less than 8 nanometers, but the negative charge on albumin, the negative charge on the basement membrane repels the negatively charged albumin. So you have no filtration of albumin. Albumin is not filtered, right? Not filtered. Please remember, as far as albumin is concerned, when I say effective diameter, why do I say effective diameter, right? What is effective diameter? Albumin is actually elliptical. This is elliptical, ellipsoidal in shape, right? Elliptical, or what is known as ellipsoidal in shape. Yes? It looks like this, right? Longitudinally, its diameter is almost 15 nanometers. This way, the diameter is just about 5 nanometers, but the effective diameter is 7 nanometers, right? Effective diameter is 7 nanometers. right? So remember, albumin is not being filtered. The reason for this mainly is, even though the size is less than 8 nanometers, the reason being that the negative charge on the basement membrane repels the negatively charged albumin. Why not 4 nanometers negative? 4 nanometers negative. Now the size is so small that the negative charge on this small 4 nanometer size particle is not important. Have you understood? For example, if you look at bicarbonate, bicarbonate is a negatively charged ion, but this is freely filtered. This is freely filtered. Why freely filtered? Because size is very small. Size is very small, so the negative charge is not going to be important. But in a particle which is close to 8 nanometers, the negative charge becomes important. Yes, yes, positively charged particles will be easily filtered, isn't it? Negative and positive attract each other. Opposite charges will attract. Like charges repel. Right? So remember, size bicarbonate is going to be a freely filtered ion because the size is very small. Albumin is not being filtered because of number one, size is close to 8 nanometers, and number two, because of the negative charge. Right? Okay. Now the why not B? Because positive charge, na beta? Positive charge will be attracted by the negatively charged basement membrane. Like charges repel, unlike charges attract. Any? All right. So least filterability, like I said, 7 nanometers negative. Yes? All right. Now, when you look at the next important point, and that is, what are the pressures which are responsible for filtration, right? Let's see, which are the pressures which are responsible for filtration? Let's discuss this. Pressures which are responsible for filtration. Now, this is the glomerular capillary, right? This is the Bowman's capsule. Now, I have discussed with you what are the push forces and the pull forces. We discussed this in the first chapter. Push is the hydrostatic pressure. Pull force is the colloid osmotic pressure. So which are the pressures here? Here you have hydrostatic pressure of the glomerular capillary, which is called PGC, and there is a pull force which is called pi GC, colloid osmotic pressure of the glomerular capillaries. PGC is push force, hydrostatic, and pi GC, which is the pull force. What is PGC? This is the hydrostatic pressure. Glomerular capillary, hydrostatic pressure. Glomerular capillary hydrostatic pressure. What is pi GC? This is the glomerular capillary colloid osmotic pressure. Glomerular capillary colloid osmotic pressure. Then you have a push force in the Bowman's capsule, PBC, and you have a pull force of the Bowman's capsule, that is pi BC. So what is PBC? PBC is Bowman's capsule hydrostatic pressure. And what is pi BC? This is Bowman's capsule colloid osmotic pressure. Bowman's capsule colloid osmotic pressure. So these are the 4 forces which are responsible for filtration. Which are these 4 forces? Please appreciate the direction of the arrow. PGC, which pushes the fluid from the glomerular capillary into the Bowman space. Pull force, which is the colloid osmotic pressure of the glomerular capillary. it will pull the fluid back into the capillary. PBC, hydrostatic pressure of the Bowman's capsule, pushes the fluid from the Bowman's capsule into the capillary, and pi BC, which will pull it. Now, out of these, which is the largest force? The largest force is the PGC. This is the largest force. PGC is the largest force. Now, pi GC, which has a direction opposite to PGC, will oppose it. PBC opposes PGC. Pi BC favors PGC. So let's see. What is the net filtration pressure? What is the net filtration pressure? Net filtration pressure is PGC minus pi GC. Why is pi GC minus? Because the direction of pi GC is opposite to PGC. So PGC minus pi GC minus PBC. Why minus PBC? Because the direction of the hydrostatic pressure of Bowman's capsule is opposite to the direction of PGC. Plus pi BC. Pi BC is in the same direction as PGC. That means which are the forces which are favoring filtration? Favoring filtration will be PGC and pi BC. These are favoring filtration. What is opposing filtration? Pi GC and PBC. Forces which favor filtration will be positive, which oppose filtration will be negative. Which are the forces which are opposing filtration? Pi GC and PBC. Pi GC and PBC. Right? Now, how much is the net filtration pressure? Net filtration pressure will be, normally PGC is 45, pi GC is 20, PBC is 10, and pi BC is 0. Why is pi BC 0? Pi BC is 0 because there are no proteins in the filtrate. Filtrate is protein-free filtrate. So pi BC is 0 because no proteins are present in the filtrate, right? No proteins in the Bowman's capsule. So therefore, pi BC is 0, right? So what is my net filtration pressure? Net filtration pressure is 15 millimeters of mercury. Net filtration pressure is 15. In some books is given as 10 millimeters of mercury, but your better answer is 15 millimeters of mercury, right? There is a big controversy between the net filtration pressure. Some books say it is 15, some say 10. But like I said, better answer is 15, right? Yes, Deepak Nayak, it is oncotic pressure. Colloid osmotic pressure is the same thing as oncotic pressure. Beta, I'm Hina Kausar, I'm still saying net filtration pressure. When we say GFR, then KF will come into the picture. Okay? Now, this is as far as your net filtration pressure is concerned. PGC minus pi GC minus PBC plus pi BC. The safest answer, how much is net filtration pressure, is 15 millimeters of mercury. And like I said, also some books have said this is 10. Better answer is 15. Now, GFR, glomerular filtration rate, will be directly proportional to the net filtration pressure. Directly proportional to net filtration pressure. That means it is directly proportional to PGC minus pi GC minus PBC plus pi BC. Right? Now, if you want to remove the proportionality sign, bring an equal to sign, you have to multiply it by KF. KF into, we've already done, what is KF? KF is the ultrafiltration constant. KF into PGC minus pi GC minus PBC plus pi BC. And what is KF? KF is the ultrafiltration constant. ultrafiltration constant. And what is ultrafiltration constant? This is permeability into the surface area. Permeability into the surface area, right? So what are the factors affecting GFR? What are the factors which affect GFR? Factors affecting GFR is number one, capillary permeability. Permeability of the glomerular filtration membrane. That is the first factor which will affect GFR. Permeability, isn't it? Number two, surface area. Second factor which affects the permeability, the filtrate GFR. Number three, PGC, PyGC, PBC, PyBC. These are the 6 factors which will affect the GFR. Permeability, surface area, PyGC, PBC, and PyBC. Now let's apply this knowledge and see, right? Now let's have a look at surface area, right? Now, whenever there is an increase in the sympathetic discharge, what is the effect of sympathetic discharge on GFR? Let's try and see that. Yes. Now, whenever there is increase in sympathetic discharge, number one, it causes an afferent arteriolar. It causes an afferent arteriolar constriction. It causes an afferent arteriolar constriction. Afferent arteriolar constriction. That means there is a decreased glomerular flow. Yes. Afferent arteriole of the glomerular capillaries is constricted, less flow into the glomerular capillaries, which now causes a reduction in PGC and therefore decreases GFR. Remember, PGC is hydrostatic pressure. Hydrostatic means pressure due to a column of liquid. Right? Pressure due to a column of liquid is known as the hydrostatic pressure. If there is less flow, less column of liquid, less PGC, and PGC is a force which favors filtration. So GFR decreases. Okay? Right? Second important effect of sympathetic stimulation is sympathetic stimulation causes kinking. It causes a mesangial cell contraction. Mesangial cell contraction. Yes. If there is a mesangial cell contraction, what are mesangial cells? Mesangial cells are contractile cells. Mesangial cells. These are contractile cells. These are similar to pericytes, right? Whenever there is a decrease, I'm trying to tell you what is the effect of sympathetic stimulation on GFR. Okay? GFR causes afferent, not efferent, afferent, Harshita. This is afferent arteriolar constriction. Afferent arteriolar constriction means less flow into the capillaries. Less flow into the capillaries means increase in a reduction in the hydrostatic pressure. We have done hydrostatic pressure in the first class. Hydrostatic is pressure to a column of liquid. Less flow, less hydrostatic pressure, less GFR. Second effect of sympathetic discharge is a mesangial cell contraction. What are mesangial cells? Mesangial cells are contractile. They are like pericytes. Mesangial cells are similar to pericytes. Similar to pericytes. Pericytes are contractile cells which surround the capillaries. Yes? And if there is a mesangial cell contraction, now it causes a kinking of glomerular capillaries. नीलाम आपने एक बड़ा existential question पूछा है. Why doesn't it cause effusive constriction? The reason is because receptors are not present. जहां receptors होंगे वहां action होगा. So afferent constriction. ठीक है ना? All right. So mesangial cell contraction causes kinking. What is kinking? Kinking matlab kinking means twisting, kinking of a glomerular capillary. Kinking of glomerular capillary will decrease the surface area which is available for filtration, and decrease in surface area means a decrease in GFR, right? Decrease in GFR. So these are the effects of sympathetic. So ultimately, sympathetic stimulation is decreasing the GFR, isn't it? Sympathetic stimulation is decreasing the GFR, yes? And also, sympathetic stimulation will act on JG cells, and it increases the renin secretion. It also increases the renin secretion. Renin will also decrease the GFR. I'll just discuss the effect of renin and angiotensin with you, right? So this is the effect of sympathetic stimulation, right? What is the effect of sympathetic stimulation on GFR? Sympathetic stimulation will reduce the GFR. Yes. See, sympathetic stimulation. If you kind of remember, when does the sympathetic discharge increase? Sympathetic discharge increases in a fight, flight, or a fight, flight, or a what is it? The next one, fright reaction. Fight, flight, fright. There is increase in sympathetic discharge. Now, in a fight or a flight reaction, yes, now you want the tissue perfusion, blood flow to important organs be maintained. What are the important organs in a fight or a flight reaction? Brain, heart, muscles. Which are unimportant at this time? GI tract, kidney. Yes. So to maintain the perfusion to important organs, there is now going to be a there is going to be a decrease in GFR. Have you understood? So that the blood volume can be maintained and blood flow to important organs in a fight or a flight reaction. This is the blood flow will be maintained, like I said, by reducing the blood volume is maintained, and therefore the blood flow to these important organs, brain, heart, muscles, is going to be maintained whenever there is increase in sympathetic discharge. Easiest ways, decrease the GFR, and that's exactly what happens. Increased sympathetic stimulation will be associated with a decrease in GFR. Okay? Shreya, beta, PGC favors a filtration. Have you understood? So reducing PGC will reduce the GFR. Shreya, where is the confusion? Okay? All right. Okay. So this is the effect. So I was trying to discuss with you what are the factors which affect GFR. We said the permeability of the glomerular filtration membrane, surface area, PGC, PyGC, PBC, PyBC. Forces favoring filtration, PGC and PyBC, opposing filtration, PyGC and PBC. Abhishek, urinating during fear and fright, does it happen to everybody? Okay. Okay, Amresh, speeding up. All right. आप बाकी सबको control कर लो. I will speed up. ठीक है? Okay. Now, the next important point. Let's see what is the effect of PyGC and PBC. Yes. Let's say, supposing there is a ureteric stone. There is a ureteric stone, or let's say there is a benign hypertrophy of the prostate, prostatic hypertrophy. Now, because of obstruction, because of the back pressure, there is an increase in hydrostatic pressure of the Bowman's capsule. This is because of the back pressure. And PBC opposes filtration. So what will happen to GFR? GFR will reduce. Yes, GFR will reduce. Are we clear with that? Right? So ureteric stone or a prostatic hypertrophy, because of obstruction to flow, because of the back pressure, there is increase in the hydrostatic pressure of the Bowman's capsule, which now reduces the GFR. Right? So I've tried to discuss with you what happens with these different forces and how do they affect the GFR. Right? Okay. Now, the next important point, how much is the renal blood flow? How much is the renal blood flow? Harshita, filtration occurs in glomerular capillaries. Afferent arteriole forms glomerular capillaries, and the blood from the glomerular capillaries leaves via the efferent arteriole. Right? Now, how much is the renal blood flow? Renal blood flow. Fernando speeding up here. Renal blood flow is 1100 to 1200 ml per minute. 1100 to 1200 ml per minute. Right? Renal blood flow is almost 20 to 25% of cardiac output. 1100 to 1200, 22 to 23% of the cardiac output. Renal blood flow. Second important point, this is what is the renal plasma flow? Renal plasma flow, this is 600 to 650 ml per minute. Renal plasma flow, plasma, please remember, is 55% of the blood flow. 600 to 650 ml per minute. How much is GFR? GFR is 125 ml per minute. 125 ml per minute or 180 liters per day. Or 180 liters per day. (125 ml per minute or 180 liters per day). Next important point, what is the filtration fraction? What is filtration fraction? Filtration fraction is GFR divided by renal plasma flow. That is filtration fraction. Please remember renal blood flow and renal plasma flow. Plasma is 600 to 650 ml per minute. GFR is 125 ml per minute. What is filtration fraction? Filtration fraction is plasma flow. Is GFR? GFR is 125 ml per minute, and renal plasma flow, let's take it as 625 ml per minute. Yes, ml per minute gets cancelled. So this becomes 0.20, or this is 0.16 to 0.020 or 16 to 20%. This is what is filtration fraction, right? Filtration fraction. Filtration fraction is an important question. What is filtration fraction? This is GFR divided by the renal plasma flow. This is 125 ml per minute divided by 625 ml per minute, or 0.20. The range of filtration fraction is 0.16 to 0.20, or 16 to 20%. Basically, what does this filtration fraction mean? What is filtration fraction? See, when you look at the glomerular filtrate, if you look at the glomerular filtrate, this is an ultrafiltrate of plasma. Ultrafiltrate of plasma. Glomerular filtrate is ultrafiltrate of plasma. What is an ultrafiltrate? Glomerular filtrate is an ultrafiltrate of plasma. Ultrafiltrate of plasma is, that means it is basically plasma minus the plasma proteins. Plasma minus the plasma proteins. That is why we need to discuss. That means basically when I say ultrafiltrated plasma, what does it mean? It means basically what fraction or what percentage of the plasma which is flowing into the kidneys is being filtered to form the glomerular filtrate. Glomerular filtrate is nothing but an ultrafiltrate of plasma. This is plasma minus the plasma proteins, right? That means what fraction, what percentage of the plasma which is flowing into the kidneys is being filtered to form the glomerular filtrate. That is what is meant by filtration fraction. That means out of the plasma which is flowing into the kidney, 20% is being filtered to form the glomerular filtrate. That is what is important, right? Now, see, somebody said 700 is given. There is something known as an 700 ml per minute is given in the flashcards. Now, there is something known as an effective renal plasma flow and an actual renal plasma flow. Actual renal plasma flow is closer to 625 ml per minute. Effective renal plasma flow is 700 ml per minute. We'll discuss this a little later. Okay? Now, Dr. Lily Chanu, it is 22 to 23% of cardiac output is the renal blood flow. The filtrate is 20% of renal plasma flow, not the blood flow. Please understand. RBCs are not filtered. So the cellular part of blood is not to be considered when we are talking of GFR. What is to be considered when we are talking of GFR is plasma flow. Somebody had written, what is the significance of plasma flow? Because it is the plasma which is being filtered to form the glomerular filtrate. The glomerular filtrate is nothing but an ultrafiltrate of plasma. Now, what is the significance of knowing the filtration fraction? Let's try and see this. Now, if this is the Bowman's capsule, if this is the Bowman's capsule, afferent arteriole, glomerular capillaries, this is the afferent arteriole. This is the glomerular capillaries, and this is the efferent arteriole. Right? Now, now let's say, supposing I have a freely filtered substance, right? Supposing I have a freely filtered substance. There is a freely filtered substance, right? Prabhu Shankar, what are you writing, beta? Huh? R. Santosh Ganpat and Prabhu Shankar, 80% of plasma is proteins. What are you saying, beta? Wow. Please listen, Prabhu Shankar and all right. Supposing I have a freely filtered substance, supposing the amount of that substance what is the difference, Kruti Jagdish Bhai Patel? What is the difference between renal blood? What is the difference between blood and plasma? What is the difference between blood and plasma? Blood is plasma plus cells. So renal blood flow means the complete blood which is flowing into the kidneys. What is plasma flow? Which is just the blood minus the cells. That is called plasma flow. Why is plasma flow important as far as glomerular filtration is concerned? Because the filtrate is an ultra. I'm trying to explain what is this filtration fraction of 20%. Supposing there is a freely filtered substance, yes, freely filtered substance. Now, this freely filtered substance, 20% of that substance will be present in the filtrate, not 100%. Why so? Because only 20% of the plasma is being filtered. Have you understood? Only 20% of the plasma is being filtered. 20% of the plasma. 100 if it is a freely filtered substance, 100 in the afferent arteriole, 20% will be present in the filtrate, and 80 will be left behind. Please remember, freely filtered substance does not mean it is going to be 100% filtered. Does not mean 100% filtered in a single circulation. 100% filtered in a single circulation. 100%. That means only 80% will be filtered in, only 20% will be filtered in a single circulation. But what will happen, this 80% which is left behind will come back in the next circulation, and another 20% of the 80 will be filtered. Right? In the third circulation, another 20%. In a fourth circulation, another 20%. So by repeated circulation, this substance will be completely eliminated from the blood, right? This will be 20% repeated circulation will cause a repeated circulations. Repeated circulation cause a 100% elimination, removal of the substance from the blood. Akhilesh, there is a difference between amount and concentration. Okay? Keep that in mind. Here we are talking about 20% of the total amount. 100 present in afferent arteriole, 20 is freely filtered, 20 is filtered, 80 is left behind. That 80 will then come back in the next circulation, so another 20% of the 80, right? Okay. Now, this is what is meant by a freely filtered substance, right? Okay. The next important point is, let's see. Now, let's have a look at another question. This says from afferent to the efferent arteriole. From afferent to efferent arteriole, which of the following increases? From afferent to efferent arteriole, which of the following increases? Yes? Remember, this is the afferent arteriole, this is the efferent arteriole. This is the glomerular capillary. Right? Which of the following shows an increase? PGC, PyGC, PBC, or the net pressure? Net filtration pressure. From afferent, when the blood flows from afferent to efferent arteriole, which of the following will show an increase? PGC, PyGC, PBC, or the net filtration pressure? net filtration pressure, right? Which of the, from afferent to efferent arteriole, which of the following will show an increase? PGC, PyGC, PBC, or the net filtration pressure? Now please understand, from afferent to efferent arteriole, which of the following will show an increase? Your answer will be PyGC, right? Your answer will be PyGC. Why PyGC? Because what is happening is, as the plasma flows through the glomerular capillaries, there is filtration which is taking place, but what is not being filtered are the proteins. Yes, what are not being filtered are the proteins. And what are proteins responsible for? Proteins are responsible for PyGC, colloid osmotic pressure of the glomerular capillaries. And PyGC, does it favor filtration? Opposes filtration. This, in fact, opposes filtration, right? So PyGC will show an increase. Yes. Why? Because proteins are not being filtered. Because proteins are not filtered. GC will show an increase. Now, why not PBC? Why not PBC? Please remember, PBC remains unchanged. PBC, the hydrostatic pressure in the Bowman's capsule, will remain unchanged. Why does it remain unchanged? Because whatever fluid is formed in the Bowman's capsule, it does not remain in the Bowman's capsule, it moves ahead. There is a free flow of fluid. If there was an obstruction to the flow of the glomerular filtrate, then the PBC would have increased. But now it's a free flow of fluid. It remains unchanged because of a free flow. This is a free flow of fluid. There is no obstruction to flow. If there was an obstruction to flow, for example, by a ureteric stone or by prostatic hypertrophy, then the PBC would have increased. So what shows an increase is PyGC. Now, the next important point which I'm going to discuss with you is, what is the effect of angiotensin II? What is the effect of angiotensin II on GF? Or before I take that, what is the question? Elampali Shrikant, which of the following shows an increase? I'm not asking you which shows a decrease, right? More, yes, Arpan Patel, more filtration at the afferent end, less at the efferent end. Okay. PGC will decrease. PGC will decrease. Hydrostatic pressure, as fluid gets filtered out, PGC will decrease. All right. Jagdev, I'm just discussing that. Now, next is, let's see what is the effect of efferent arteriolar constriction on GFR. What is the effect of efferent arteriolar constriction on GFR, right? Nilanjana Das, PyBC 0. It remains 0 because there is no filtration of proteins. Kya ho gaya beta? Okay. Yes, Maitre Pandey, because PyGC increases, net filtration pressure near the efferent arteriole is sometimes 0. Less filtration near the efferent arteriole. Okay. Effect of efferent arteriolar constriction on GFR. Let's try and see this. What is the effect of efferent arteriolar constriction of GFR? Now, if there is an efferent arteriolar constriction, this will increase the hydrostatic pressure. Efferent arteriolar constriction will increase. Supposing the efferent arteriole is constricted, Now the outlet from the glomerular capillaries is narrow. So because of the back pressure, the hydrostatic pressure in the glomerular capillaries will increase. And this, in fact, increases the GFR. Right? But please understand, this is seen if in a mild to moderate constriction. Mild to moderate constriction, there is increase in hydrostatic pressure and there is an increase in GFR. Yes? Please remember, efferent arteriolar constriction has got a dual effect on GFR. If it's a mild to moderate constriction, there is increase in PGC and there is an increase in GFR. Without a doubt, right? Effective efferent arteriolar constriction, it has a, like I said, it has a dual effect on GFR. Efferent arteriolar constriction has a dual effect on GFR. Has a dual effect on GFR. If it is a mild to moderate constriction, increase in PGC and increase in GFR. But I've already discussed it with you. As you go from now remember, we've discussed filtration fraction, isn't it? We've discussed filtration fraction. Now filtration fraction, what was filtration fraction? Filtration fraction was GFR divided by renal plasma flow, right? When I do an efferent arteriolar constriction, there is also an increase in the filtration fraction. Why increase in filtration fraction? Why increase in filtration fraction? Filtration fraction is GFR divided by renal plasma flow, isn't it? So when I do an efferent arteriolar constriction, I am increasing the GFR, but I will reduce the total renal plasma flow. Numerator is increasing, denominator is decreasing. So fraction increases. Why does the denominator decrease here? Please try and understand. It is like when blood flows through a plastic pipe. You put your foot somewhere. What will happen to the total flow? Total flow will reduce. GFR increases in a efferent arteriolar constriction. Why? Because GFR will increase if efferent arteriole is constricted. Hydrostatic pressure of the glomerular capillaries will increase in PGC, increase in GFR, right? But at the same time, what will happen to renal plasma flow? Renal plasma flow will now reduce. Numerator increases, denominator decreases. There is increase in the filtration fraction. Increase in filtration, how much is normal filtration fraction? 16 to 20%. Now that filtration fraction has probably become 30, 35 or 40%. So that means more fluid is being filtered. If more fluid is being filtered, what will happen to the concentration of plasma proteins in the filtrate? Concentration of plasma proteins in the glomerular capillaries increases. So there is now an increase in pi GC. More fluid being filtered, increase what is not being filtered are proteins. So concentration of proteins will now increase. This now, because now remember, PGC favors filtration, pi GC opposes filtration. There is increase in efferent arteriolar constriction, there is increase in PGC and increase in pi GC. Both are increasing. PGC favors filtration, pi GC opposes filtration. When the increase in pi GC becomes more than the increase in PGC, net result will be a decrease in GFR. But please understand, when do you see a decrease in GFR? This is seen in a severe efferent arteriolar constriction. This is seen in a severe efferent arteriolar constriction. That is when the efferent arteriolar diameter, is half to 1/3 of the afferent arteriolar diameter, and that will cause a decrease in GFR. Please listen to this once again, and that is, what is the effect of efferent arteriolar constriction on GFR? Efferent arteriole arteriolar constriction has a dual effect on GFR. If it is a mild to moderate constriction, there is increase in PGC, increase in GFR. Mild to moderate constriction, it means there is an increase in PGC and there is going to be an increase in GFR. But in a severe efferent arteriolar constriction, when the efferent arteriolar diameter is half to 1/3 of the afferent arteriolar diameter, there is a decrease in GFR. Now, what causes this reduction in GFR when there is a severe efferent arteriolar constriction is because efferent arteriolar constriction increases filtration fraction. Filtration fraction normally is 20%. If there is increase in filtration fraction, more fluid being filtered, concentration of proteins in the glomerular capillaries rises. Normally also there is a rise in concentration of proteins in the glomerular capillaries. Now that rise is much more. Proteins in glomerular capillaries is responsible for pi GC. So there is a large increase in pi GC. There's an increase in pi GC as well. Efferent arteriolar constriction will increase the GFR as well as increase the filtration fraction and therefore increase pi GC. There is increase in PGC, there is increase in pi GC. PGC favors filtration, pi GC opposes filtration. Now, when the relative increase in pi GC is more than the increase in PGC, GFR reduces. And that reduction in GFR is going to be seen in severe efferent arteriolar constriction. So my question here, efferent arteriolar constriction causes increase in GFR or decrease in GFR? A, B. Bolo, increase in GFR or a decrease in GFR? What is going to be my answer? If you have to choose between, now this does not say mild, moderate, severe, nothing. In that case, my better answer is increase in GFR, because please remember the decrease in GFR is seen only when the efferent arteriolar constriction is very severe. Yes? Same question, but now the options are increase in GFR, decrease in GFR, increase followed by a decrease, D, decrease followed by an increase. If you have this, then your better answer becomes C. There is an increase when it is a mild to moderate constriction, but later, as the constriction becomes more and more severe, there is a decrease in GFR. So in that case, if such an option is given, then my answer becomes C. Right? So this is going to, why is there a decrease? Because of a larger increase in pi GC. Right? So this is as far as the effect of efferent arteriolar constriction on GFR is concerned. Please understand, mild to moderate constriction, increase in PGC, increase in GFR, severe efferent arteriolar constriction, there is going to be a decrease in GFR. Now, the next important point, what is the effect of angiotensin II? Effect of angiotensin II on GFR. Effect of angiotensin II on GFR. Now, angiotensin II In low concentration, now remember, angiotensin 2 causes efferent arteriolar constriction. Angiotensin 2 causes an efferent arteriolar constriction. Remember, A attacks E. Angiotensin attacks E. It affects efferent arteriole. It causes efferent arteriolar constriction. Right? So remember, angiotensin 2, that means angiotensin 2 has a dual effect on GFR. This has got a dual effect on the GFR. Angiotensin 2 has a dual effect on GFR. Right? Angiotensin 2 in a low concentration, causes increase in GFR. But angiotensin 2 in a high concentration causes decrease in GFR. Have you understood? So angiotensin 2 affects efferent arteriolar constriction. Yes? So I've just discussed with you the effect of efferent arterial constriction, GFR, dual effect. Mild to moderate constriction increases GFR. Severe constriction decreases GFR. Similarly, angiotensin 2 also has a dual effect on GFR. Low concentration increases GFR. High concentration decreases GFR. Now the important point is, what causes angiotensin 2 to be in a low concentration? What causes angiotensin 2 to be in a high concentration? What are the causes? Angiotensin 2 is in a low concentration in most physiological conditions. Most physiological condition, and also in renal artery stenosis. Renal artery stenosis. These are the conditions which will cause angiotensin 2 to be in a low concentration. When is angiotensin 2 in a high concentration? This is angiotensin 2 is in a low concentration in most physiological conditions as well as renal artery stenosis. When is angiotensin 2 when is it in a high concentration? In conditions such as hemorrhage, hypovolemia. Krishna Gupta, listen to this. Hemorrhage, hypovolemia, these are conditions where now there is a massive increase in sympathetic discharge, huge increase in renin secretion from the JG cells. The angiotensin 2 is in a high concentration, which reduces GFR. Most physiological conditions in renal artery stenosis, angiotensin 2 is in a low concentration, increases GFR. Hemorrhage, hypovolemia, dehydration, those are the conditions where angiotensin 2 is in a high concentration and reduces GFR. Krishna, I hope I've answered your question. Now comes what is a very important clinical application of this knowledge. Please listen to me once again. Effect of efferent arteriolar constriction in GFR, dual effect. When mild to moderate efferent arteriolar constriction increases GFR, severe efferent arteriolar constriction reduces GFR. Angiotensin 2 affects efferent arteriole. A attacks E. Angiotensin 2 in low concentration increases GFR, in high concentration reduces GFR. What are the conditions which will cause angiotensin 2 in low concentration? Most physiological conditions and renal artery stenosis. Which are the conditions which will cause a high concentration of angiotensin 2? Hemorrhage, hypovolemia, dehydration. These are when angiotensin 2 in a high concentration. Now, what is the clinical application? Clinical application is, let's see what happens in a patient of bilateral renal artery stenosis. There is a patient of bilateral renal artery stenosis. Let's see what happens in bilateral renal artery stenosis. Renal artery is stenosed. Yes. These are the two kidneys here. Yes. In a patient of bilateral renal artery stenosis, what happens? Remember I told you in a patient of renal artery stenosis, angiotensin 2. Now, angiotensin 2 is in a low concentration. There is increase in angiotensin 2, but it is in a low concentration. And in angiotensin 2 in low concentration will now increase the GFR. And in fact, this is what maintains the GFR in these kidneys. In a patient of bilateral renal artery stenosis. Bilateral renal artery stenosis, angiotensin 2 in, see, because remember, a patient of bilateral renal artery stenosis, blood flow to the kidneys is reduced. A reduction in blood flow would have meant a decrease in GFR. Decrease in GFR would have meant accumulation of toxic metabolites. But that not happened because simultaneously, in this patient of bilateral renal artery stenosis, angiotensin 2 is in a low concentration, and that is what is maintaining the GFR in these kidneys. But remember, one of the commonest presentations of a patient of bilateral renal artery stenosis is hypertension. And in hypertension, one of the commonest drugs that you use are ACE inhibitors. Supposing I give a ACE inhibitor to this, if I give an ACE inhibitor to this patient, if I give an ACE inhibitor to this patient, yes, ACE inhibitors are commonly used antihypertensives. If I give ACE inhibitor to this patient, there is no angiotensin 2. What was maintaining GFR is now gone, and the patient now goes into a renal shutdown. The patient will go into a renal shutdown. This is the reason why ACE inhibitors are contraindicated. ACE inhibitors are contraindicated in a patient of bilateral renal artery stenosis. A patient of bilateral renal artery stenosis. Yes, these are contraindicated in patients of bilateral renal artery stenosis. Yes, if I give an ACE inhibitor, angiotensin 2, which was maintaining the GFR in these kidneys, now that angiotensin 2 is gone, what was maintaining the GFR is gone, and the patient goes into a renal shutdown. So ACE inhibitors are contraindicated in patients of bilateral renal artery stenosis. So remember the effect of efferent arterial constriction on GFR, it has a dual effect. Now, the next important point, let's go on to the next thing, and that is, I've already discussed that, Disha Goel, that the effect of sympathetic stimulation is a decrease in GFR, already done that. Okay. Now, the next important point, as long as this is concerned, is renal handling of different substances. Let's see, what is the renal handling of different substances? Renal handling of different substances. First is not filtered at all. Renal handling of different substances, not filtered at all. Not filtered at all will be proteins. Proteins are not filtered at all. Number 2, the second is freely filtered. Freely filtered. not reabsorbed. Freely filtered, not reabsorbed, not secreted. Freely filtered, not reabsorbed, not secreted. Freely filtered, not reabsorbed, not secreted. Let's see this. Freely filtered, not reabsorbed, not secreted. So that means if I have 100 of that substance in the afferent arteriole, 100 of the substance in the afferent arteriole, 20 is filtered and 80 is left behind. I've already discussed that with you, right? So freely filtered, not reabsorbed, not secreted, this is going to be inulin. Freely filtered, not reabsorbed, not secreted is inulin, right? And that is why we take the clearance of inulin. We take the clearance of inulin is taken as equal to GFR. Clearance of inulin is taken as GFR. Why? Because whatever inulin you get in the urine is only by the process of filtration, right? So clearance of inulin is taken as equal to GFR, right? It is only by the process of filtration. Freely filtered, not reabsorbed, not secreted. Let's see the third category. Third category is freely filtered and completely reabsorbed. Freely filtered and completely reabsorbed. What is freely filtered and completely reabsorbed? That means this 20 which is filtered is now completely reabsorbed and you have 0 in the urine. Which are the substances which are going to be freely filtered and completely reabsorbed? Whatever 20% you got in the filtrate are reabsorbed so that you have 0 in the urine. These are freely filtered and completely reabsorbed substances like glucose, amino acids, bicarbonates, freely filtered and completely reabsorbed. Glucose, amino acids, bicarbonates. Please remember, bicarbonates are extremely precious ions for us. Extremely precious ions for us. Because bicarbonate is my most important buffer in the ECF, right? So bicarbonate is a small ion, freely filtered, but it is completely reabsorbed. At least that is if bicarbonate levels are normal, that means they are less than 24 millimoles per liter. If they are normal, then they are going to be completely reabsorbed. Freely filtered and completely reabsorbed will be glucose, amino acids, bicarbonates. Let's look at the fourth category. Fourth category is freely filtered and partly reabsorbed. Freely filtered and partly reabsorbed. Substances like freely filtered and partly reabsorbed. Okay. Freely filtered and partly reabsorbed. Substances like electrolytes, sodium, chloride. Yes. Then freely filtered and partly reabsorbed electrolytes. Then urea. 52% of urea is reabsorbed. 52% of urea is reabsorbed. Water. Water is also, you know that GFR is 180 liters per day, but urine produced is 1 to 1.5 liters per day. So almost 178.5 to 179 liters of filtered water is going to be reabsorbed, right? So this is your, but it's partly, it's not completely, obviously, right? Fifth category, freely filtered and completely secreted. Freely filtered and completely secreted. What is freely filtered and completely secreted? This is the Bowman's capsule here. Freely filtered and completely secreted. So supposing I have 100 of the substance here, 20% is filtered and 80% is left behind. This 80% will be secreted so that I have 100 of that substance in the urine. This is called freely filtered and completely secreted, right? And which are the substances? Which are the substances which are going to be freely filtered and completely secreted? This is going to be para-aminohippuric acid in a low concentration. Para-aminohippuric acid in a low concentration. Low concentration means it should be less than 20 milligrams per deciliter. Freely filtered and completely secreted is less than para-aminohippuric acid, right? Which is in low concentration, less than 20 milligrams per deciliter. That is why we take the clearance of para-aminohippuric acid in low concentration as equal to the renal plasma flow. Freely filtered and completely secreted will be para-aminohippuric acid. Clearance of para-aminohippuric acid is equal to the renal plasma flow. Number 6, freely filtered and partly secreted. Freely filtered and partly secreted. This is going to be para-aminohippuric acid. Para-aminohippuric acid in high concentration. And number 2 is creatinine. Creatinine is a product, creatinine is freely filtered and slightly secreted, right? What is creatinine? Creatinine is freely filtered and slightly secreted, freely filtered and slightly secreted, right? So please see this once again. These are the 6 categories of substances. The first one is not filtered at all. These are going to be proteins. Freely filtered, please remember again, freely filtered does not mean 100% filtered in a single circulation. It means 20% is filtered. So freely filtered, not reabsorbed, not secreted is inulin. And clearance of inulin is taken as GFR. Why? Because you can see this. The inulin which is present in the urine is only by the process of filtration. So the clearance of inulin will be equal to the GFR. Freely filtered and completely reabsorbed, that means this 20% which is reabsorbed as it flows through the tubules, this 20% is reabsorbed. The 20% which was filtered is now reabsorbed. So that you have 0 in the urine. That is glucose, amino acids, and bicarbonates. Freely filtered and partly reabsorbed, all the electrolytes, sodium, chloride, magnesium, calcium, these are freely filtered and partly reabsorbed. Urea, water, freely filtered and completely secreted. 20% is filtered, 80% which is left behind will be secreted in the tubules, not in the glomerulus. Glomerulus is a site of filtration. Secretion will take place in the tubules. This is para-aminohippuric acid in low concentration. So clearance of para-aminohippuric acid in low concentration is equal to renal plasma flow. Freely filtered and partly secreted, this is para-aminohippuric acid in high concentration. And creatinine. Creatinine is freely filtered and slightly secreted. Next, let's go on to what is the concept of clearance. I just told you that the clearance of inulin is equal to the renal plasma flow. And clearance of para-aminohippuric acid is equal to clearance of inulin is equal to GFR, and clearance of para-aminohippuric acid in low concentration is equal to renal plasma flow. Right? So let's try and understand. What is clearance. What is the formula for clearance? What is the definition of clearance? Now, clearance of a substance. Clearance of a secretion means from blood to the tubule. Absorption means from tubule to the blood. Clearance of substance is volume of plasma Clearance is volume of plasma free of that substance. Clearance of substance is volume of plasma free of that substance in unit time. Clearance of a substance is volume of plasma free of that substance, completely free of that substance in unit time. That means the unit for clearance is ml per minute. Why ml per minute? Volume of plasma free of that substance is in unit time. Right? So many ml of plasma free of that substance in unit time. This is known as clearance. Right? Clearance is a mathematical concept. Clearance is a mathematical concept, and this is a mathematical concept, and this is going to be used for assessment of renal function, right? This is used for the assessment of renal function. It's a mathematical concept which is used for the assessment of renal function, right? What is the unit for clearance? ml per minute, volume of plasma free of that substance in unit time, right? Now, we have discussed that the clearance of inulin is equal to GFR. I've already discussed it with you. Why is it equal to GFR? Because inulin is absorbed, not secreted. Yes? Whatever inulin you get in the urine is only by the process of filtration. Clearance of para-aminohippuric acid in low concentration is equal to the renal plasma flow. Why renal plasma flow? Because para-aminohippuric acid in low concentration is freely filtered and completely secreted. So whatever you get in the urine is similar to what you had in the afferent arteriole. 100 in urine, 100 in afferent arteriole. So this is measuring the renal plasma flow. Para-aminohippuric acid clearance in low concentration is equal to renal plasma flow. Clearance of inulin equal to GFR, right? Now, what is the formula for clearance? Clearance of any substance X is urinary concentration of X into rate of urine flow divided by plasma concentration of X. What is UX? This is urinary concentration of X. This is V is rate of urine flow. This is plasma concentration of X. This is the formula for clearance. UV by P, urinary concentration of X into rate of urine flow divided by plasma concentration of X. Yes, urinary concentration of X into rate of urine flow divided by plasma concentration of X. Now, urinary concentration, if urinary concentration is in milligram per ml, rate of urine flow is in ml per minute. Please remember, I have been saying that this is rate means it is per unit time. Divided by plasma concentration of X, which is also in milligram per ml. Both of these will get cancelled. So your final unit for clearance is in ml per minute. I've already discussed that. What is clearance? Volume of plasma free of that substance in unit time. This is in ml per minute. Formula for clearance, UV by P. U is urinary concentration of that substance. into rate of urine flow divided by plasma concentration of X. So if you see this, urinary concentration is in milligram per ml. Rate of urine flow is in ml per minute, and milligram per ml is the plasma concentration. So these two will get cancelled, and ml per minute will be the clearance, for the unit for clearance. All right, so this is the unit for clearance. Like I said, clearance of inulin equal to the GFR, right? Clearance of inulin is equal to GFR. Clearance of para-aminohippuric acid in low concentration is equal to the renal plasma flow. Now, an important point here is, if a substance is reabsorbed, its clearance will be, if a substance is reabsorbed, now what do I mean by reabsorbed? If this is the Bowman's capsule and the tubule here, yes, this was afferent arteriole, glomerular capillaries, efferent arteriole, this forms the peritubular capillaries, afferent arteriole, glomerular capillaries, efferent arteriole, and these are the peritubular capillaries. So if a substance is reabsorbed, supposing there is a substance which is being filtered and it is reabsorbed, so what will happen to the clearance of that substance? Its clearance will be less than or more than? It will be less than the clearance of inulin. Yes? If a substance is reabsorbed, whether it's partly reabsorbed or whether it's completely reabsorbed, that's not important right now. If a substance is reabsorbed, that means it is re-entering into the plasma. What was the definition of clearance? Clearance is volume of plasma free of that substance in unit time. So if a substance is reabsorbed, it is re-entering the plasma. So clearance of that substance will now be lower than the clearance of inulin. All reabsorbed substances will have a clearance which is less than the clearance of inulin. And let's see the next one. If a substance is secreted, yes, what does that mean? If this is my Bowman's capsule and forms the tubules, afferent arteriole, glomerular capillaries, efferent arteriole, peritubular capillaries. So if a substance is secreted, that means it comes from the plasma. So if a substance is secreted, its clearance will be more than the clearance of inulin. It will be more than the clearance of inulin. All secreted substances, whether it's partly or completely, will have a clearance more than the clearance of inulin. Yes, a substance which is reabsorbed will have a clearance less than the clearance of inulin. If the substance is secreted, its clearance will be more than the clearance of inulin. So that means, answer this question. Which of the following has maximum clearance? Which of the following has maximum clearance? Okay? Inulin, glucose, urea, or creatinine? Which of the following has the maximum clearance? Inulin. Now, inulin, please remember, the clearance of inulin is equal to GFR, isn't it? Clearance of inulin is equal to GFR, isn't it? Like I said, glucose is a substance which is reabsorbed. right? So this is glucose is a substance which is glucose and urea are both reabsorbed. So the clearance of these substances, clearance will be less than the clearance of inulin. We've already discussed that. Keep in mind what is the definition of clearance. Volume of plasma free of that substance. If a substance is reabsorbed, it is re-entering into the plasma. So volume of plasma will be, which is free of that substance in unit time, will be less than the clearance of inulin. Creatinine is secreted. So its clearance of creatinine will be more than the clearance of inulin. Yes, but only slightly more. Because remember, there is only a slight secretion. But out of these four answers, it is going to be creatinine. Have you understood? Of course, if para-aminohippuric acid was in the options, then that is the answer. But out of these four options, your best answer becomes creatinine. Creatinine is slightly secreted. So the clearance of creatinine is slightly more than the clearance, slightly higher than the clearance of inulin. Why so? Because creatinine is freely filtered, and slightly secreted. Any secreted substance will have a clearance more than the clearance of inulin. Yes? Now, if I have to do the clearance of creatinine, let's try and see this. What is the formula for the clearance of creatinine? See, where does creatinine come from? Creatinine comes from muscle metabolism, isn't it? What is the clearance of creatinine? Remember, the clearance formula for clearance is UV by P. So this will be urinary creatinine into rate of urine flow divided by plasma creatinine. Yes, this is the formula for clearance of creatinine. Urinary creatinine into rate of urine flow divided by plasma creatinine. Right? Rate of urine flow divided by plasma creatinine. That means if I have to do a creatinine clearance, firstly, what do you tell the patient? Patient is asked to collect his 24 hours urine. Collect 24 hours urine. He has to urinate in a can or something, and he has to collect his 24 hours urine. Why do I want him to collect his 24 hours urine? Because from 24 hours urine output, I can get rate of urine flow, isn't it? ml per minute. If I know that this is the amount of urine produced in 24 hours, I can calculate how much is the urine produced in 1 minute. So we ask the patient to take his 24 hours urine so that we can calculate his rate of urine flow, right? Now you have so much of urine with you, 24 hours urine, you can get a urine sample, take a urine sample and you can get urinary concentration of creatinine. Take a plasma sample and you can get plasma concentration of creatinine. So it's so easy to do creatinine clearance, isn't it? The only thing which you have to do is ask the patient to collect his urine over 24 hours so that you can get rate of urine flow. From that lot of urine that you have, you can take a sample and you get urinary creatinine. Take one plasma sample and you will get plasma creatinine, right? If you have urinary concentration, rate of urine flow, plasma concentration of creatinine, you can easily calculate the creatinine clearance. And creatinine advantage is creatinine is an endogenous product. It is produced by muscle metabolism. So creatinine clearance is very, very easy for us to do. Yes, this is, like I said, creatinine clearance is easy for us to do. For inulin clearance, if I want inulin clearance, I need, again, urinary inulin into rate of urine flow divided by plasma inulin. That means for 24 hours, we need to, for 24 hours while he's collecting his urine, you have to give, inulin has to be given by a continuous IV infusion. it has to be given by a continuous IV infusion, right? For 24 hours, you have to give inulin by a continuous IV infusion, right? Please see this once again. If I have to do creatinine clearance, I need three parameters. I need urinary creatinine, rate of urine flow, plasma creatinine. How do we get rate of urine flow? Collect 24 hours urine, calculate rate of urine flow. Urinary creatinine, plasma creatinine easily determined. Clearance is easy. If I have to do inulin clearance, for 24 hours that he's collecting his urine, I have to give inulin by a continuous IV infusion. Because inulin is not produced inside the body. It has to be given IV infusion. So creatinine clearance, slightly easier to do. But what is more accurate? Inulin clearance, right? So for most accurate for GFR estimation, which is more accurate for GFR estimation? More accurate for GFR estimation, is it clearance of inulin or is it clearance of creatinine? Your answer will be clearance of inulin, isn't it? This is more accurate for GFR estimation. Creatinine clearance is slightly more than the inulin clearance. But the only advantage of creatinine clearance is easier because creatinine is endogenous, right? So this is so if the question says for GFR, which of the following is used for GFR estimation? Is it going to be clearance of inulin or clearance of creatinine? If I have to choose between the two, I will still go for inulin. Inulin clearance is, like I said, the most accurate. And when do I do a GFR estimation? When I am suspecting a renal pathology, right? So clearance of inulin is going to be preferred over clearance of creatinine, even though creatinine is easier to do. But creatinine clearance will only give you a rough idea because creatinine clearance is not accurate. Continuous matlab? Continuous, Gautam, throughout the 24 hours. Blood levels have to be maintained. Steady levels, steady blood levels have to be maintained. That is what is meant by continuous IV infusion. Okay. Now we come to, and so this is as far as your clearance is concerned. What you have to keep in mind, what is the definition of clearance? Volume of plasma free of that substance in unit time. What is the unit for clearance? ml per minute. Clearance of inulin used for GFR. Clearance of para-aminohippuric acid at low concentration is meant for renal plasma flow. Creatinine clearance, slightly easier to do, but what is more accurate is inulin. And which of the following, if you have to choose between inulin and creatinine clearance, you will still go for inulin because creatinine may be easy, but not accurate. Okay, next. The next thing is, what do you understand by free water clearance? You know, all this nibba nibbi which you use, I actually Googled it last time. I saw your comments and I didn't know what was nibba nibbi. Dinosaur, I'm a dinosaur. And I actually Googled it to see what is it. All right, free water clearance. Now, what is free water clearance? Now, free water clearance is the definition of free water clearance is free water clearance is the rate of urine flow minus the clearance of osmoles. Free water clearance is rate of urine flow minus the clearance. Concentrate karo. Rate of urine flow minus the clearance of osmoles. Okay? This is clearance of osmoles. Now, like I told you, what is the general formula for clearance? UV by P. UV by P. So clearance of osmoles is urinary osmolality into rate of urine flow divided by plasma osmolality. Right? This is what is meant by free water clearance. Now concentrate. Free water clearance is an important concept. Then you'll say, "Samajh nahi aaya." Concentrate karo, okay? Okay. Now, what is free water? What is clearance? Now, what is free water clearance? This is rate of urine flow minus the clearance of osmoles. And like I said, what is the general formula for clearance? UV by P. What is clearance of osmoles? This is urinary osmolality into rate of urine flow divided by plasma osmolality, right? This is rate of urine flow minus the clearance of osmoles. Now, what do you understand by free water clearance? Let's try and see this. Now, this is basically what do you mean by. Now, if urine is isotonic with plasma, if urine is isotonic with plasma, if urine is isotonic with plasma, right? If the urine is isotonic with plasma, let's try and see what will happen to the free water clearance. Free water clearance is comments karo, enough. Concentrate on this. एक छोटी सी बात बोली उसके ऊपर से लिखते चले जा रहे हो, बस करो. If urine is isotonic with plasma, what does this mean? This is going to be rate of urine flow minus urinary osmolality into rate of urine flow divided by plasma osmolality. Now, if urine osmolality and isotonic means urine osmolality and plasma osmolality is the same. So that means these two will cancel each other out. So what you get, rate of urine flow minus rate of urine flow of free water clearance will be 0. So if urine is isotonic with plasma, free water clearance is 0. Now, in simple words, I've told you mathematically what is going to be the free water clearance if the urine is isotonic with plasma. Free water clearance is going to be 0. Now, let's try and understand this conceptually. Now, when I look at it conceptually, see, both urine and plasma are nothing but solutions. They have solutes, they have a solvent, isn't it? They have solutes and they have a solvent. So let's see this here. If this is plasma and this is urine, the solutes in plasma, we have already done, these are 300 milliosmoles per liter. So the shaded area is solute, unshaded is solute-free water, right? Plasma and urine are both solutions. So I'm representing plasma as the shaded area, which is solutes, 300 milliosmoles per liter, 290. So I'm taking it as 300 solutes, and the remaining is water. Now, urine is isotonic with plasma means what? That is, urine also has a solute load of 300 milliosmoles per liter. So that means the excretion of water in urine with respect to water in plasma is the same. So we say free water clearance is 0. Have you understood? It is with respect to the water in plasma. Loss of water in the urine or excretion of water in the urine is the same as the water in the plasma. So we call it free water clearance is 0. So we've done it mathematically. We are trying to do it conceptually. Right? Loss of water in the urine is with respect to water in the plasma. Water in urine with respect to water in the plasma is the same. So we say free water clearance is 0. Let's try and do this in a little more detail. Urine is hypotonic. If urine is hypotonic, and remember this is also with respect to plasma, that means it is dilute with respect to plasma. Isn't it? That is what is meant by hypotonic. Now, urine is dilute with respect to with respect to plasma. That means, let's take an example. If plasma has an osmolality of 300 milliosmoles per liter, plasma has an osmolality of 300 milliosmoles per liter. Urine has an osmolality of 100 milliosmoles per liter. Yes, it's a dilute. I'm just taking it for an example. Let's say urine has an osmolality of 100. So what is going to be the free water clearance? Free water clearance will be urinary osmolality, which is 100, into rate of urine flow. Sorry, this will be rate of urine flow minus urinary osmolality, which is 100, into rate of urine flow divided by plasma osmolality. So that means this is V minus 1 upon 3V, which is equal to 2 upon 3B. That means now, in other words, free water clearance is positive. If urine is dilute, more water in urine with respect to plasma, that means loss of water in urine or water in urine is more than the water in plasma, or free water clearance is positive. And I've shown it to you mathematically as well. You get a positive answer. If urine is dilute, free water clearance is positive. There is more solute free water in urine as compared to plasma. Free water clearance is positive. Let's see another example. If urine is concentrated, if urine is hypertonic, and what do I mean by hypertonic? Hypertonic means it is a concentrated urine. Concentrated urine, that means it has a higher osmolality as compared to plasma. Yes, higher osmolality is compared to plasma. So that means, again, I'm going to show plasma and urine over here as, let's see, plasma, let's say, has solute load 300 milliosmoles per liter. The urine is concentrated, for example, in summers, isn't it? We are all passing concentrated urine. Yes, yellow colored urine, because we have insufficient water. So what happens is ADH secretion increases, concentration of urine. Let's say urine has an osmolality, let's say, of 600 milliosmoles. Right? So let's try and see it mathematically first. What is going to be the free water clearance here? Free water clearance is rate of urine flow minus urinary osmolality 600 into rate of urine flow divided by 300. That means it is V minus 2V, or it's going to be minus V. That means free water clearance is negative. Please understand this. If urine is isotonic with respect to plasma, free water clearance is 0. If urine is dilute, free water clearance increases or becomes positive. If urine is concentrated, less water, more solutes in urine, that means free water clearance is negative, or free water clearance decreases. Yes, and I'll do a couple of questions here with you. Tell me what will happen in diabetes insipidus. What will happen to free water clearance? Does it increase or does it decrease? Free water clearance, this will increase or decrease. In diabetes insipidus, there is excretion of large volumes of extremely dilute urine. Extremely dilute urine. So free water clearance increases. Yes, free water clearance increases. Next question. If there is a maximal antidiuresis, what will happen to free water clearance? Sweating, marathon runner, sweating, hot, humid day, maximum secretion of ADH. Free water clearance, is it going to be positive? Is it going to be negative? Is it going to be positive? Is it going to be negative? It is going to be concentrated urine means negative free water clearance. Yes? Another question. This was a neat question. This said free water clearance is minus 1.2 ml per minute. Urine is dilute or concentrated? Urine is concentrated. Have you understood? Yes? It means urine is going to be a concentrated urine. Please remember this once again, and that is, if urine is isotonic with respect to plasma, free water clearance is 0. If urine is dilute or hypotonic, more water, less solutes, free water clearance is positive. If urine is concentrated, hypertonic, that means less water, more solutes, free water clearance is negative. Okay? This is the concept of free water clearance. Okay with that? Chalo. So I think everybody seems to have got it. Okay? All right. It's 1 o'clock. We can take a lunch break. Okay? Okay. Tell me any questions? Any questions? Any questions? See, please understand, Andrew Murray Xavier. When you look at free water clearance, it all depends upon the hydration of the patient. Have you understood? Hydration of the patient. It basically is trying to tell you if urine is dilute, if a patient diabetes mellitus, if a patient is taking adequate water, more than adequate water, yes, urine is dilute, free water clearance is positive. Urine is concentrated, free water clearance is negative. That's a simple thing. ठीक है. Sweating, yes, sweating अगर excessive sweating है, water intake कम है, concentrated urine है, like for instance आजकल गर्मियों में है ना, all of us are passing a dark colored urine, so free water clearance is negative. Free water clearance कम हो गया, ठीक है? All right. So let's take a lunch break till sleep paralysis. क्या है बेटा? Nancy Bharat, this is sleep paralysis is basically, it is a locus coeruleus mediated. When you say sleep paralysis, that is occurs typically in REM sleep. That means the person, it's an experience. Sometimes it happens to us. Somebody has, you can hear somebody calling out your name. You want to get up, but you feel as though there is absolutely no strength in your arms and legs. You feel that is what is meant by relative paralysis. Okay? Sheikh Ahmed, free water clearance is not commenting on the total volume. It is commenting on whether urine is dilute or concentrated. Difference is, have you understood? When I'm talking over here is osmolality per liter, right? Urine output is only in liters. So there's a difference between the two. Okay? Sheikh Ahmed, have you understood this? Volume के ऊपर comment नहीं है, concentration के ऊपर है. ठीक है? How inulin clearance is equal to GFR? Because inulin, whatever is being filtered is no reabsorption, no secretion, isn't it? Okay. Ureteric stone concept क्या है बेटा? Ureteric stone अगर है, तो flow of urine is obstructed. If flow of urine is obstructed, then back pressure will increase the hydrostatic pressure in the Bowman's capsule, and hydrostatic pressure of the Bowman's capsule opposes GFR. So that reduces the GFR. Okay? Mansa, RBF and RPF. Blood flow means plasma plus cells. Plasma flow means only the plasma. We are interested only in plasma flow, isn't it? Because plasma is filtered to form urine, right? Okay. Please scroll up. Okay. Not simultaneously, they occur cyclically. Gautam, REM and NREM sleep occur cyclically. Okay. Diabetes insipidus is lack of ADH, dilute urine, large volumes of extremely dilute urine. एंटी-डायूरेटिक हार्मोन अगर बढ़ेगा हिमानी तो यूरिन कॉन्सेंट्रेटेड होगा, और यूरिन अगर कॉन्सेंट्रेटेड होगा तो फ्री वाटर क्लियरेंस कम हो जाएगी. ठीक है? ऑलराइट. फ्री वाटर क्लियरेंस इक्वेशन क्या है? इफ पर्सन हु हैज डन मैराथन एक्सेसिव स्वेटिंग, पर्सन टेक्स